Hello everyone. The topic for discussion is an overview of vesiculobullous disorders. In vesiculobullous disorders, are formed. Blisters are the fluid-filled cavities formed within or beneath the epidermis, which contain tissue fluid and plasma. If blisters are of less than 0.5 cm diameter, they are known as vesicles, and if they are more than 0.5 centimeters in diameter, they are bullae. So, for the diagnosis of vesiculobullous disorder, skin biopsy is necessary, and the biopsy should be taken of virgin disease and not of the therapeutic altered skin if possible. If therapy is started, it should be stopped, if at all possible, at least a week before the surgery. So the skin biopsies, they are assessed for vesiculobullous disorders. First, on the basis of blister separation plane, the level of blister formation. They are divided as at the level of intraepidermal or dermal and subepidermal. If the blister is intraepidermal, if the location is subcorneal, then it could be in Malaria crystallina, staphylococcal scalded skin syndrome, pemphigus falacius, bullous impetigo, IgA pemphigus, subcorneal pustular dermatosis, erythema toxicum neonatum, transient neonatal pustular melanosis, and acropustulosis of infants. At the level of spinous, spongiotic dermatosis, friction blister, Malaria rubra, incontinea pigmenti, IgA pemphigus, Hailey-Hailey disease, and epidermolytic hyperkeratosis. The suprabasal blisters are characteristic of pemphigus vulgaris, paraneoplastic pemphigus, and Terrier's disease. The subepidermal blisters, they are seen in epidermal bullosa simplex, thermal injury, erythema multiforme, and herpes gestationis if the basal keratinocyte necrosis or cytolysis. Blister is formed due to keratinocyte cytolysis. If blisters are formed due to epidermal basement membrane zone destruction, then the causes are bullous pemphigoid, dermatitis herpetiformis, linear IgA dermatosis, junctional epidermolysis bullosa, suction blisters, thermal injury. Bullous SLE, epidermolysis bullosa acquisita, linear IgA dermatosis, porphyria. The dermal blisters are seen in penicillamine-induced blisters and bullous amyloidosis. After assessing the plane of separation or the blister formation, we will then go for the mechanism of blister formation. The mechanism of blister formation is either spongiosis. Spongiosis is accumulation of extracellular fluid within the epidermis with resultant separation of the keratinocytes. So, due to accumulation of fluid, extracellular fluid, spongiosis will give stellate appearance to the keratinocytes, and these keratinocytes are viable. These stellate keratinocytes will lead to disruption of the desmosomes, leading to blister formation. They are almost always associated with an infiltrate of lymphocytes within the epidermis and around the superficial vessels. So, if the cause of blister formation is spongiosis, then stellate keratinocytes are formed, which will lead to disruption of desmosomes, leading to blister formations, and that blister will contain lymphocytes. So the diseases in which blisters are formed due to spongiosis are eczematous dermatitis, miliaria, pemphigus, early stage, and transient acantholytic dermatosis, one pattern. Second mechanism is acantholysis. In this, there is loss of appropriate keratinocyte cell-cell contact, and histologic evidence of acantholysis includes presence of rounded keratinocytes, while in spongiosis there is stellate form of keratinocytes. In this, rounded keratinocytes with large nuclei with peripheral condensation of the chromatin, prominent nucleoli, and condensed cytoplasm. These acantholytic keratinocytes are also viable. This is seen in pemphigus, transient acantholytic dermatosis, Hailey-Hailey disease, Darier's disease, and irritant dermatosis. Third mechanism of blister formation is reticular degeneration. It results from the ballooning degeneration, that is intracellular edema, with secondary rupture and death of the keratinocytes. So in this, the keratinocytes are dead. The remaining desmosomal attachments connect strands of ruptured keratinocyte membranes and cytoplasm to the intact keratinocytes, giving the epidermis an irregular meshwork appearance. Viral infections and eczematous dermatitis are the examples. Blister formation due to cytolysis, when there is disruption of keratinocytes. Due to friction or heat or any physical agent, there is shearing of keratinocytes from one another, leading to fluid-filled blisters. Minimal friction may lead to cytolysis in patients whose keratinocytes do not have normal structural matrix and desmosomes, like in epidermolysis bullosa simplex or epidermolysis bullosa of Koch-Weber type. So the diseases which have blister formed due to cytolysis are epidermolysis bullosa simplex, epidermolytic hyperkeratosis, friction blisters, erythema multiforme, and irritant dermatitis. And the last mechanism for blister formation is basement membrane zone disruption, either due to primary structural deficiencies or humoral and cellular immunological mediated damage. The diseases are bullous pemphigoid, cicatricial pemphigoid, linear IgA dermatosis, dermatitis herpetiformis, epidermolysis bullosa acquisita, junctional epidermolysis bullosa, and epidermolysis bullosa dystrophica. Now, the infiltrating inflammatory cells in vesiculobullous dermatosis. In porphyria, there is no infiltrate. In epidermolysis bullosa classical, there is no infiltrate. Bullous pemphigoid cell poor and bullous pemphigoid cell rich, they have principal cell type eosinophils. In cell poor, the infiltrate is minimal, while in cell rich, infiltrate is present. Herpes gestationis, it also has eosinophils. Spongiotic dermatitis, it has lymphocytes. Erythema multiforme also has lymphocytes. Paraneoplastic pemphigus, it has lymphocytes in the blisters. Interphase dermatitis, like in lichen planus or erythema multiforme. Dermatitis herpetiformis, the principal infiltrate or inflammatory cell is neutrophils and infiltrate is present. Linear IgA dermatosis also contain neutrophils. EBA inflammatory, it has neutrophils or mixed population of neutrophils and eosinophils. NTP200 pemphigoid, it contains inflammatory infiltrate of neutrophils or mixed neutrophils and eosinophils. Bullous SLE, it has neutrophils. Cicatricial pemphigoid has mixed population of neutrophils or eosinophils or only eosinophils or lymphocytic infiltrate, band like infiltrate in mucosa only. Thank you.